Good afternoon. I'm Emily Austin, Managing Director of Cooper Surgical Fertility Genomic Solutions in the UK and Ireland, and a very warm welcome to this webinar, Actionable Results for Your Patients the First Time using the ERPeak Endometrial Receptivity Test. We're very lucky to have multiple speakers joining us today. We have chairing and as question master for today's webinar, Sheila Johal. Sheila is the manager of the PGTM genetic counselling team at Cooper Genomics. In addition to managing the PGTM genetic counselling team, she also provides genetic counselling to patients seeking pre-implantation genetic testing and serves as the genetic counselling lead for ERPeak. She came to Cooper Genomics after more than 9 years at Metro Health Medical Center in Cleveland, Ohio, where she provided prenatal, general and cardiovascular genetic counselling. Sheila graduated with a master's degree in medical and molecular genetics with a focus in genetic counselling from Purdue University, Indianapolis in 2006. Prior to attending graduate school, she also received a Bachelor of Science in Biology and a Bachelor of Arts in Psychology from Kent State University. She has a specific interest in disorders of hemoglobin, CFTR-related infertility, and is passionate about educating genetic counselling students. We also have today presenting for us 2 speakers, one of whom is Mike Large. Mike earned his PhD from Baylor College of Medicine, where he focused on the intersection of progesterone and growth factor signalling and their role in endometrial receptivity. Whilst finishing his work there, he was recruited by Mark Hughes of Genesis Genetics to open a research and development PGS laboratory in Houston, Texas. Mike quickly rose to prominence as a technical expert and was instrumental in the adoption and implementation of next-generation sequencing in Genesis genetic labs across the world. Shortly after being acquired by Cooper Surgical, he was promoted to Director of Genomic Laboratories, overseeing PGTA testing for approximately 1,000 patients per month for 2 years. He was then promoted to his current role, leading research efforts in genomics. His team recently lead and continues to develop state-of-the-art analytical methods for interrogating reproductive genetics. And our other speaker today, we're very pleased to have Kristine McWilliams. Kristine serves as the Medical Director, Genomics for Cooper Surgical Fertility and Genomic Solutions. She is instrumental in defining the path of the genomics division and works closely with cross-functional teams. Kristine also manages the genetic counselling programme and guides the team's clinical decision-making, ensuring clinicians and patients are equipped with genomic information that would inform their transfer decisions. Dr. McWilliams has been in the field of PGT since 2013 and has a particular expertise in PGTM. She obtained an MD degrees from the University of Pennsylvania School of Medicine's Medical Scientist Training Programme. Her doctorate is in the field of human genetics and epigenetics. So we've got 2 presentations today. If you have questions during the presentations and whilst the panel are presenting, please do enter them into the chat box. We've 60 minutes in this webinar today, so there's plenty of time to answer your questions after the presentations. So thank you very much for your attention. And Kristine, I will now hand over to you as our first speaker.
Thanks very much, Emily. It's my pleasure to join you today. And let's get these slides working. And today I'll be presenting some of the clinical considerations regarding endometrial receptivity testing. By way of disclosure, as Emily mentioned, I am a paid employee of Cooper Surgical. To the broad question to start us off, why consider endometrial receptivity testing? Well, as we know, the endometrium and endometrial lining are critically important in IVF success and implantation and sustained pregnancies. And in recent years, there's been quite a bit of progress made on the embryo side of this equation, with the improved ability to select the healthiest embryos for transfer by either improved morphology assessment or more specifically with pre-implantation genetic testing for aneuploidy or PGTA, which allows the ability to select chromosomally normal embryos for transfer. Yet besides the improvements that we've made with embryo selection, still pregnancy with IVF is not assured or guaranteed. And in fact, even the highest performing IVF clinics with transfer of a euploid embryo only achieve success around 70% of the time on average. And there are a number of important things that we could look at to try to get us to that goal of 100% pregnancy rate within IVF. And some of those factors are listed here. And one that we will focus on in a little bit more detail today is recurrent implantation failure, or RIF. So as we strive towards that goal of 100% pregnancy rate with IVF, there's an emerging body of literature that suggests that the endometrium, and specifically looking at the genomic profile of the endometrial lining, is in fact a good target to improve these pregnancy rates. And over the past years, there's been actually quite a number of studies published looking at this, specifically looking at the ability to determine a genomic signature of gene expression that is associated with a receptive endometrium, which means an endometrium most suitable to achieve implantation of a transferred embryo. And in fact, tests have been developed to predict whether a woman's endometrium is receptive before transfer. And this, of course, forms the basis of endometrial receptivity testing. With that transfer of an embryo timed with the receptive endometrium being what is known as personalized embryo transfer. And this slide here looks at some of the early studies that were done to look at at personalized embryo transfer and to see whether or not it was able to improve pregnancy rates in at least a subset of patients. The study that is on the left was published in 2014 and looked at a same patient cohort. In this study, patients that were offered standard embryo transfer that did not achieve an ongoing pregnancy were then offered a personalized embryo transfer with endometrial receptivity testing to see if this improved their chances of ongoing pregnancy. And in fact, found that for this cohort of patients, that is what was observed. Those patients that had not achieved pregnancy with the standard embryo transfer were more likely to reach that goal with the personalized embryo transfer. The study on the right looks more specifically at recurrent implantation failure patients. And this was a study within this demographic of patients that looked at achievement of implantation, ongoing pregnancy, and live birth, whether standard embryo transfer was offered versus personalized embryo transfer. And here again, for these patients that were offered the personalized embryo transfer, they did see an improvement in all of those important categories. So knowing that some patients can, from these early studies, appear to benefit from endometrial receptivity testing, it begs the question of which patients could such testing be offered to. As we just described, there is some demonstrated clinical utility in RIF patients. There's also been some work in adenomyosis patients that shows some potential benefit in these patients as well. However, in recent years, there has been work done and some studies published that looked at potentially expanded applications, such as patients with perhaps only limited embryos to consider for transfer. For example, patients with limited euploid embryos or patients who are hoping to achieve multiple pregnancies from a single IVF cycle, or interesting whether endometrial receptivity testing might be appropriate for the general IVF population. On this point, there have been two very recent studies published that did look at potential benefit of ER testing in the general population. And perhaps not surprisingly, as far as studies with genomics can go, there were some conflicting results found in these studies. Just to highlight them for you, in a little bit more detail. The first study to be published was a 5-year multi-center RCT that looked at ER testing in either personalized, frozen, or fresh blastocyst transfer. This was published by Simone et al. Last fall. And more recently, in fact, just a couple of months ago, there was a second study published in Fertility and Sterility that looked at the potential improvements in pregnancy rates and live birth rates with ER testing in specifically a first embryo transfer cycle. Now, with the Simone study, did find some improvements with offering ER testing in the way that they conducted their study. Specifically, they found that an improvement in live birth rate over a year, monitoring these patients over a year. Whereas the second study, who again just looked specifically at that first embryo transfer cycle, did not see an improvement for patients who were offered the personalized embryo transfer. However, there were some pretty important differences in the way that these studies were set up, and also ultimately in the patients who were enrolled and proceeded through the treatment arms. And that could be highlighted, for example, in the differences they saw within patients who were offered the ER testing in the percentage that were receptive or non-receptive. So as you can see from the Simone study, by far most patients that were in the ER treatment arm were receptive. However, in the second study, most patients in that ER treatment arm were not receptive. Again, perhaps reflecting back on the patient demographics of who was included in that study. So I think at this point we would say there certainly needs to be additional work done looking at endometrial receptivity testing and benefit for the general IVF population. However, to get back to this topic of recurrent implantation failure in patients with recurrent implantation failure, which, if you recall, the early clinical utility studies for endometrial receptivity testing did find benefit. This is a costly diagnosis to make. It's typically defined as failed implantation after 4 or more high quality embryos and 3 or more IVF cycles, and is estimated in some studies to be about 7% of women will end up with this diagnosis in the IVF space. But it's a challenging diagnosis to make and difficult to assess the true prevalence and the outcomes secondary to high rates of patient IVF dropout. And certainly, as we know, there are a good number of patients that may not have 4 high quality embryos to begin with, or the ability to afford or proceed with 3 IVF cycles. So almost certainly underestimated the true prevalence, which is a shame because that does obviously impact our ability to really find effective treatments to help with this disorder. And so I think clearly there is more work that we can do to better understand the full capability of ER testing and to really pinpoint the patients who can expect to receive the most benefit. from this test. And I'm sure that we could all agree that to the basis of a solid clinical study, clinical utility study in genomics is a solid genomic test. And fortunately, ER test quality is also improving right along with our efforts to understand its benefit. As clinicians, of course, we always strive to provide patients actionable results the first time. And this is especially true when a procedure is involved, and particularly a somewhat invasive procedure such as endometrial biopsy is. In general, quality genomic tests should provide to clinicians the lowest possible rate of no results, consistently accurate results, and also critically highly reproducible results. And to the production of, or the ability to offer a high quality test in this regard was certainly has certainly been and continues to be the guiding focus in our development of our ERPeak test, which we are proud to say that we feel does provide these actionable and accurate results for patients and clinicians on the first time. As my colleague Mike will describe to you in more detail later, this is a test that's powered by artificial intelligence, as all of Cooper Surgical's genomic tests are, to give an innovative approach to correct for sample variability. Again, you'll hear about that a little bit more in a few minutes. Offer 96% accuracy, and importantly, offer very low no result rates. In fact, 5 times lower compared to the ERA test that the previous studies that we described were based upon. In addition to accurate and reproducible results with low no results, we're trying to strive for clarity in the test results that would be released to you. We offer 4 category result reporting: prereceptive, receptive, postreceptive, or non-receptive, with recommended times for transfer offered for those pre and post-receptive results. As a reminder, ER testing is done during a mock controlled FET cycle, or also potentially through a natural cycle with precise timing. And the goal of the mock cycle is to take the endometrial biopsy on that same day that you would then plan to transfer in the embryo transfer cycle. This result here shows if what we would expect if the ERPeak result came back as receptive, in which then the recommendation would be to perform the transfer on that same day, typically P+5, that the endometrial biopsy was obtained. However, some patients will be found to have pre-receptive results, which means that if the biopsy was taken in the mock cycle at P+5, if a pre-receptive result was obtained, it means that the endometrium was found to be not quite at that P+5 at that optimum receptivity status for the transfer. And so the ERPeak recommendation would be to delay the actual embryo transfer within the embryo transfer cycle by 24 hours. Also, some patients could be found to be post-receptive in the mock cycle, meaning that at the time the biopsy was taken, the optimum receptivity had already occurred, And so the endometrium was in a post-receptive state. And if this is the result, the ERPeak results will direct the clinician to consider moving the embryo transfer cycle forward by 24 hours during that embryo transfer cycle to, again, better align the endometrium with the, so that it's most receptive at the time of transfer and give highest opportunity for success. As an end-to-end process, the ERPeak test process is 4 steps. The first being the endometrial biopsy, processing and samples shipment to our laboratory, where the AI-driven analysis is conducted. Results will be reported in the means that we just described, allowing you as a clinician to schedule that precision embryo transfer. And with that, I thank you very, very much for your time. I look forward to a lively discussion later on in this session. And I'd like to turn the presentation over to my colleague, Mike Large, who will tell you a little bit more about the technology and the advantages of the ERPeak test. Thank you.
Hello, everyone. Confirmation, Kristine, since you're still able to unmute, slides up and everybody can hear me?
Looks good, Mike.
Great, thanks. And so Kristine did a really good job of describing the what and the why, and I'm going to take a few minutes to go over some of the technical components of how we actually achieve this. And so while I will cover it today, if you need to go back and either share this webinar or talk with folks in your team, we are excited to have this new white paper available, which goes through these concepts really written out, and it's a really nice piece. Kristine already hit on some of the highlights here, our innovative approach. I'm going to talk about today how we've proactively managed and mitigated the impact of tissue heterogeneity and variability we get in our samples. And this has come together to give us our net 96% accuracy. We've also made conscious assay choices in which we've chosen the most sensitive platforms, i.e. QPCR, which mitigate the impact of small tissue or lower quality tissue, because QPCR is the most sensitive platform for detecting rare species within a population, or it can, even because of the small amplicons, handle smaller and lower quality molecules, excuse me. And so that's the highlight overview of what we'll go through. And really, whenever we talk about endometrial receptivity and the window of implantation, it's important to remember and understand that the endometrium is the cyclical organ that undergoes dynamic changes each month. So generally, we think of the first day of the menstrual cycle as really triggered by that fall in steroid hormones. Let's turn on my laser here. You have the fall in hormones in the last cycle, triggering menstruation and shedding of the lining, about 7 days. Then not shown here are the ovaries. And at this time, follicles begin being stimulated. Those cells at that time are producing estrogen, and estrogen really drives the proliferation and the regrowth of that endometrium until you get a surge in luteinizing LH. This triggers ovulation. The remaining follicle differentiates in the corpus luteum, begins producing progesterone, and really you have this nice transition to progesterone mediated and dominated biology. And it's really this temporal and kinetic change that helps drive that window of implantation and the underlying physiology within the endometrium. Kristine just covered some of this, but again, the important concepts here are that I went over the natural cycle with LH. Typically, we think of the window of implantation as 7 days following that LH surge. In IVF, we often do hormone replacement cycles to have a little bit more control and precise timing and administration of exogenous hormones. There, we often look at it as 120 hours after commencement of progesterone treatment, or P+5. Some patients are what we call prereceptive. In other words, they have a delayed window. And so if you were to look at P+5, you would see that they are not yet receptive. Their window will be occurring later. and other patients, a very small subset of patients, are in fact postreceptive, meaning that if you look at day 5, their window has already come and gone. And this is obviously very important in the IVF setting because we have control over the timing of replacing that embryo. And it's important that that embryo be transferred at a time that coincides with that brief window of implantation. Typically, it's not 100% fully understood, but we generally look at the window of implantation lasting around 30 to 36 hours as a sort of emerging consensus. There's such a thing. When we get into how can we really evaluate and assess the timing of the endometrium, I think we look back to all the way in the late 50s. We were using histology to do endometrial dating, a very famous grading method developed by a physician named Noyes. But ultimately, what we came to find is that there are limitations to subjective interpretation. And depending on where you biopsy, you can see some different cellular morphologies. So there are limitations to visual assessments of endometrial dating. There are other things like ultrasound, although I tend to think of ultrasound as sort of a one-tail predictor. Certainly if you're below a certain thickness, often viewed as 6 to 7 millimeters, you know that you could be in for a reduced prognosis or a lower prognosis. But just because you are in the excess of that threshold does not guarantee good results. And so those are some of the limitations with visual assessment of endometrial dating. Really dating back to about 10, 15 years or so, we've really had the omics revolution. So advancements in technology have paved the way to look at biomolecules, DNA in things like PGT or PGT-A or M, and in endometrial receptivity testing, it's mRNA gene expression. As we have technological platforms that can really survey and interrogate a credible number of molecules, that's really become a very powerful approach, and both through how we've leveraged that to look at the window of implantation. There are some emerging technologies that assess endometrial receptivity, for example, while the hormones and that temporal interchange that I've talked about are important for the window, the endometrium is also an organ system that's exposed to the external environment. And so it often needs to be on the combative defensive, and that's part of receptivity. And so in the context of an inflammatory environment, that can be preclusive of an implanting embryo. But I think that some of that's really a newer concept that we're still seeing clinical evidence emerge for the importance of things like the microbiome and the immune system. When we look at some of that omics, I'm not going to go into all the details here, but to suffice to say, it can be complicated. There are lots of proteins ultimately are the drivers of physiology. There are lots of proteins that are driving things occurring in the embryo. At the same time, the embryo and the endometrium are signaling to one another. And then the various cell types within the endometrium are also triggering cascades. And this really gets to when we look at the cell types within the endometrium, we think about 95% of them are epithelia, shown as both here. This is the luminal epithelium. This is the cross-section of an epithelial gland, and stromal cells. Stromal cells are shown as these spindly fibroblasts, and when they begin to become exposed to progesterone, they can decidualize and change in their shape. There are, of course, blood vessels. We have endothelial cells, and we talked a little bit about those immune cells. There are macrophages and natural killer cells and various other immune components that are important both in maintaining that homeostatic environment, but also promoting things like tissue reorganization for vascularization and supporting of that underlying embryo. Now, importantly, these cell types, again, going back to the epithelia and the stroma, respond differently to the hormones. And so one hormone may promote a biomarker in one compartment, and it may inhibit that same biomarker in the other compartment. And so the way that we build omics-based gene signatures is illustrated here. And so we've gone, hopefully you've had a chance to see some of our initial white papers. First released ERPeak. You'll recall that we started off with almost 200 putative biomarkers that we found through extensive combing of the literature, and we tested those biomarkers in patients with multiple biopsies within a cycle and the changes, and we found 85 that were statistically significant. We then applied some learning techniques to really determine which of those statistically significant biomarkers were most predictive, and then we could use things like random forest to generate decision trees in silico that helped us do classification. And the way all of that works is really simply, here I have a simple illustration of biomarker A, and what we can see going from left to right is that progression of the window. Again, receptive would be that middle period, and in this circumstance, we see that biomarker A is increasing through that window. Very conveniently for didactic purposes, biomarker B does just the opposite. And so in the prereceptive state, we see that there are high expression levels of biomarker B, and as the window progresses, expression of biomarker B goes down. Biomarker C is one of those biomarkers that's really great because it's uniquely expressed in one given cell or one given physiology. So we see here in the receptive column, it's expressed highly, but in the prereceptive and the postreceptive phases, we have low expression. And so ultimately what we do is we combine these expression levels of all of the biomarkers within the panel, and we develop a signature that is indicative of a physiological state. Now, getting to some of the more complicated parts, I already mentioned that the actual different cell types can respond differently. And so here, again, if you recall biomarker A, that was going up, but that was in the epithelial cells. When we look at the stromal cells, biomarker A is actually going down. And I switched the order for that easy explanation. Biomarker C was that perfect one, and even in the stroma in this example, it was high in receptive, but it's low in the stromal cells. And it does the opposite in the stromal cells. It's high in prereceptive and postreceptive. And then back to biomarker B, that was the one that was decreasing in the epithelium, but it's not expressed in the stromal cells at all. And the reason this is important is because endometrial biopsy is typically a blinded procedure, and it can be imprecise. You don't necessarily know the cellular composition you're going to get. And so if we look at something like this, the way our analytical techniques, I mentioned QPCR work, is we try to quantify the number of biomarker molecules present, and then we have to normalize that to the number of cells present. And so there are biomarkers that are just common to human cells, and so we can use that to normalize our signatures. And so if we look in this example, we ultimately have a total of 5 biomarker copies per cell. In biopsy number 2, where there are 40 copies of the biomarker in 5 cells, we get 8 copies per cell. And then in biopsy 3, we're ultimately looking at 2 copies per cell. Ultimately, the correct answer here is that there are 10 copies of this biomarker in epithelial cells, and there's in fact no difference. And so this demonstrates how tissue heterogeneity and the impact of the biopsy can actually drive changes. Is this really relevant? Does this happen? Here's some data that we've put together that is both a model and represents what we've seen over the last few years. And so in blue, what we've done is we've taken epithelial cells and we've taken stromal cells from cell culture systems, and we've mixed them together at known ratios. And that's plotted with that blue trend line. And we use some of our tissue compartment predictors to really establish that. When we look at clinical samples, what we see is really there is a significant variability. Typically between 20 and 60% of the biopsy can be composed of stromal cells. And so this was one of the reasons that really drove us to take this approach. And we identified this tissue heterogeneity was an issue, and we came up with an innovative way to address it. When we look at really statistical classification, how well does a given test sample or a live clinical sample fit within the models? We see that ultimately we have very, very strong classification utilizing this. And when we look at some of our low quality samples, I probably wouldn't consider this statistically significant. We're seeing even strong, we don't see a statistical difference in strength of classification, but we're seeing definitely strong performance here. One concept that I do want to point out in terms of strength of fit in the classifiers, we like to think about biology as black and white. Are you in group A or group B? But in reality, biology is a continuum. As we talked about that transition from the estrogen driven biology to the progesterone driven biology, and there is no real time point with perfectly clear separation. So that's why when you see here in terms of strength of fit within the receptive class, that's really the broadest window. And certainly there can be earlier in the receptive window or later in the receptive window, but in our models, they're still in the receptive window versus a thresholded shift into a prereceptive or post-receptive status. So in sum, from the approach we took is we reevaluated our gene panel to make sure we were using markers that best represented and gave us the most information possible. We leveraged that to first quantify the cell types present and then normalize the biomarkers to their cellular compartments. And ultimately, this has given us really robust and accurate results. Shown here in a confusion matrix, we look at the performance of the ERPeak test versus the same biopsy performed on a competitor's test, and we see a 96% accuracy here. This compares to, I mentioned that initial white paper where we looked at our first launch of ERPeak several years ago, and we're again seeing potentially a trend towards improved accuracy, if anything at all, certainly non-inferiority compared to what's available out there today. Importantly, I hinted at our conscious design decision to use QPCR because of its strengths in detecting low quantity or low abundance biomolecules, and also being able to leverage typical amplicons in QPCR around 100 to 150 base pairs. And so that allows us to overcome some quality issues. So when we look at tissue or mRNA that has failed to produce results on other platforms that have more stringent criteria or less robust approaches, we are in fact able to generate valid and useful results. And Kristine covered really nicely why that's so important in the clinical setting. Additionally, there are some samples that really give what I would call a non-window of implantation, non-obvious progesterone-driven signature, and we call those non-informative. Most often, they have some indication of being proliferative, but there can also be a lack of progesterone-driven signature that may not necessarily be indicative of a proliferative phase, but it's showing an absence of progesterone-driven biology. Over the past few years, what we've seen is really only, this is a very rare classification result for us, and other samples, we've been able to identify those types of signatures. And so very low classification rate in that group. So in summary, in terms of how and what we've done is we've really taken an innovative approach to minimize the impact of tissue heterogeneity. Do that by first looking at the various cellular compositions within the biopsy, and then we've custom chosen our biomarkers that can give us the maximum informativity with them. Doing non-inferiority type comparisons, we have very high accuracy of 96%, and we're currently investigating some of the clinical outcomes of those that have different results to find out if potentially we did actually come up with our reclassification may have been the more appropriate classification. And ultimately, because of our design decisions, we have extremely low no result rates. And so with that, we would welcome any questions that have come into the Q&A or any that you have now.
Okay, I just want to make sure everybody can hear me. Perfect. Thank you, Mike and Kristine, for those excellent presentations. They were very, very informative. So we do have a couple of questions, and I think I'm going to start with a question that I think is probably best for Mike. So Mike, one of the questions that came in is, what are the advantages of using the AI or the machine learning in endometrial receptivity testing?
Yeah, it's a good question. I think it really comes down to more on building the classifier and producing the most accurate predictor than it does necessarily looking at just today's sample. How does it compare? Our AI and machine learning approaches are based on driving the classifier and its design. And so ultimately what that means is, as I mentioned, we had many putative markers that we were interested in, and we found 85 that were statistically different between 2 different time points. And so how could we really know which of those was most important and which of those was giving us the most information? We could have made predictions based on reports that we've read, but really this is where we deployed some of the machine learning concepts of why don't the statistical models tell us what the most important classifiers are and what gives us the most accuracy in ways that we don't come to the table with our own biases, which did the data reveal to us. And so I think that's really where we've leveraged that and it's performed pretty well for us.
Excellent, thank you. We have a couple of clinical questions that are coming in. So I think we're going to just start. I'm just going to start with the first one, and then we'll see how far down we get. So the first question that has come in that is a little bit more clinical in nature is first a question about how often does ERPeak give a no result? And Kristine, if you want to take that, you can. Otherwise, I'm also happy to answer that one.
And it's actually quite rare, right? And you know, very pleased with that result. So we, what is it, around like the range of maybe like 1% of the time that we're viewing it now. Of course, when you get to these small numbers, if like an extra one comes in, right, it can kind of skyrocket a bit on us, but we're very close to the 1% range.
And I think a nice follow-up, oh, I'm sorry, I'm just getting a little bit of feedback. Sorry about that. I think actually a nice follow-up to that question, just that statistic, which is, why do we get those results, right? What is it about a particular sample that might generate a no result or a non-informative result? And that is a question that comes in through our genetic counseling channels pretty often, actually.
Yeah. The no result one is the one that's a little bit easier to address. And I think I touched on it a little bit in the slides there. Maybe the question came in before then. And really that comes down to when we look at, so the biomarkers that we're using are gene expression, and it's mRNA, which can have, it's not as nearly as stable as DNA as a biomolecule. It's even, I would say, less stable than protein. And so some of the things that we look at are, is there enough tissue to work with? And again, going back to QPCR, really being able to detect just a few molecules in a sample, we have the highest sensitivity. And so from that perspective, we can actually handle very small biopsies. We talk about really our requirements are just a few millimeters of tissue, or imagine a few grains of rice. So with that, we have sufficient material to look at. Another component is how has the tissue been handled and what has its storage conditions been like. We use buffers that really stabilize our biomolecules. It's important that those the buffer that the tissue is placed in does require some time to penetrate the tissue. And so it's important that that biopsy be placed in the buffer and then directly to a refrigerator, 4 degrees Celsius, to try to stabilize that those biomolecules in the tissue while the buffer penetrates the tissue. Once it does that, we really have some nice stability well within our required shipping conditions and expectations. But potentially some things happen just through maybe different physiologies. There can be part of our inflammatory response, many viruses, for example, use RNA and DNA. And so if we're in an inflammatory state, our bodies can produce a defense system that really tries to degrade some of those things. And so different conditions can happen. But again, going back to QPCR, the way QPCR works is really a PCR that's based on average, maybe 125 base pairs of DNA, and where we amplify that little amplicon. And again, if we're getting any degradation at all through whatever reason, we're still able to handle that pretty well. And didn't go through it today, but you can heat RNA and 95 degrees Celsius. And the longer you heat it for, the more degradation you get. And we've done time courses where we've really beat up some not real patient samples, but in the R&D lab, we've really done some damage to RNA and looked at our ability to get consistent signatures, starting with unadulterated RNA to really degraded RNA, and we're still able to get a very high concordance in our signatures. And so we're doing pretty well with that as well. The last sort of element is really what's the quality of tissue within that biopsy. And so certainly some biopsies can have a high degree of blood or potentially mucus. Those are obviously not where we're getting our gene signatures from. So depending on really what we have within that biopsy, those things can actually interfere with some of the enzymatic reactions and those types of things. We actually do our best to try to mitigate that. And so we have sort of a gross dissection in which, again, because we have a very small tissue demand, we're able to go in that biopsy and do sort of a micro dissection of what looked like good quality tissue. So again, we try to mitigate that. And I think all of those come together to give really those actionable results and a low no result rate.
And just to follow up on that, Mike, obviously, I think you've explained very well why, you know, our request is that we receive the endometrial biopsy to our laboratory within 7 days of the biopsy to have best chance of producing a result. And also why we really do recommend that, you know, bigger is not necessarily better on the term, you know, when it comes to the biopsy specimen, both from the ability to stabilize and retain, you know, the RNA that we're looking at, but also to, you know, to avoid interference of other cells such as blood cells. Sheila, did you have anything yourself to add to that?
No, actually, thanks. Those, you know, as you mentioned a minute ago, a no result is not a common result, but it certainly is a result that generates a lot of questions. And so these questions certainly do come up, but no, nothing to add here. Those answers were phenomenal. Thanks, guys. So I'm just checking our chat box, and there's actually a question that I think I am going to take if Mike and Kristine will indulge me, because this is a question that I get quite frequently, and it's about a category of results that is also not very common but generates a lot of questions, and that is the result that is classified as non-receptive. So this is a little different than a no result. A no result means just that we haven't been able to identify if a sample is receptive, pre-receptive, or post-receptive. But a non-receptive means that result can't be classified into any of those three things, and the endometrium appears to just be non-receptive. Those results are very, very rare. Just to put it in perspective, since ERPeak testing has been in place, we have had less than 10 cases that were reported as non-receptive. But as everyone on the call can likely imagine, those generate a lot of questions. And, you know, where we are is, at the end of the day, there's not really much information in the published literature about how to follow up on these results or what an appropriate course of treatment might be for these patients. So in general, when a clinician reaches out to us to say, hey, you know, we've received this non-receptive result, this is not something we're familiar with, can you give us some guidance or how can you help us? I'm generally the one who's taking that call, and I'm happy to try to help. I think in general, there are three things to keep in mind. So the first thing is to just ensure that the patient has been taking the medications as she has been directed. And that might seem very intuitive, but we all know patients don't always understand directions. They may say they've taken something when that hasn't been the case, or it wasn't taken at quite the right time. And we really want to make sure that the medications were taken appropriately. Assuming that's confirmed, then the next thing is, was the biopsy done at what is the recommended time? And just as a quick reminder, in a natural menstrual cycle, biopsy is recommended to be taken at LH+7. In a hormone replacement cycle, biopsy is recommended at P+5. And I just want to take 1 second to say that that really is the recommended time for biopsy, regardless of when you think a transfer might take place, because we give transfer recommendations for both day 3 transfer and day 5 transfer, but the biopsy itself should be taken either at LH+7 or P+5, particularly for that initial biopsy. And assuming that that was done at the appropriate time, then the next question is, could this patient have any underlying endometrial issues that could be impacting her results? And then once you've got the answer to those questions, then that might lend you to thinking about doing a second biopsy. You may have a discussion with a patient about potential changes in medication, but at this time, there isn't any published guidance about like, this is step 1, if you get this result, this is step 2, this is step 3, this is what we always follow. So each non-receptive result really is case-by-case evaluation.
Yeah. And Sheila, just to underscore that as well, and that is why on the ERPeak test, with the non-receptive, there won't be that sort of guidance about, push it a day, bring it forward a day, push it back a day, because it really is, in addition to being a relatively uncommon result, very specific to the patient, the medication regimen, what that patient's clinical background might be.
All right, I know we're almost done. We've got about 7 minutes left, but I do want to take a second to address one other question. Sorry, Mike, most of these are clinical, but I think this is also I think this is also a question that comes through relatively frequently when clinics are reaching out with questions about samples and results, and that is a question along the lines of, my patient had an ERPeak or an endometrial receptivity test on this date. Now we're 2 or 3 or 4 months later. Do I need to repeat it, or is that result still applicable? Kristine, did you want to take that one?
Sure. Yeah. Maybe we can both speak to this, given that it's a question that you get coming in. But what we have seen, I guess I would say, stay tuned to some research that will be coming out that looks at this, directly with the ERPeak test. But what we see is certainly that, and this has been supported by literature in the past, looking at other endometrial receptivity testing as well, that certainly within at least several months, i.e. if a patient needs to undergo several transfer cycles to achieve that pregnancy, the ERPeak recommendation does stay valid. If you are sample a patient before the first transfer cycle, we would expect to see the same result on the ERPeak test for at least several months. And really work that we're looking that we've done and work that others have published as well seems to suggest that as long as the patient's own physiology, specifically, most specifically BMI, stays consistent over a period of time, that we would predict that the endometrial receptivity results would also stay consistent over that period of time. But obviously, again, we're talking about a mock cycle with a specific medication administration, schedule, and those sorts of things would need to stay specific, or stay consistent as well, just as we would recommend from the biopsy to endometrial transfer cycles too. But we are seeing that, fortunately, the results seem quite stable over a period of time.
Okay. Mike, did you have anything you wanted to add to that?
I was debating, but I think Kristine really covered it. Certainly, again, within that, we have some, don't want to talk about it too much until we find out if it's going to be published, but we've done a study looking at that consistency, and we had the patients weren't intended just to do a consistency cycle, but they were actually being monitored over time, and we had an average of the patients within our study had an average of 3 months separation, and they showed pretty good consistency. Some of the initial publications did show up to 3 years, is some of the indication. But really, as Kristine mentioned, patients can change their own physiology. We look at BMI as the most well understood, and that's because adipose is actually estrogenic. So, fat cells can produce estrogen. And again, we talk about that transition between an estrogen-driven biology to the downregulation of that signature and the promotion of the progesterone signature. And so if you have increasing levels of natural endogenous estrogens, you can actually impact that signature and that timing. But beyond that, we think that from our experience, and the two of you probably know better than I do, but infertility patients, they're very conscious of how long procedures take. They're eager to have a happy story and sort of move on with their treatments. And so most often folks are doing a biopsy to find out what their window looks like, and then they want to be doing transfers as soon as possible thereafter. And in that sort of typical use case scenario, we feel that the results are pretty simple.
Excellent. I think that that's it for our questions. So it looks like, well, actually, sorry, I've got one more. That's okay. We have 3 minutes to spare, so nobody hang up yet. Okay, last question is, so I'm going to actually ask this to both Kristine and Mike. So where do you think ERPeak is going? Where do you think endometrial receptivity testing is going? Tell us about the future.
Crystal ball gazing. Well, so hopefully it's taking us to 100% success, with pregnancy and live birth rates for IVF patients. That would be spectacular. But if not that, I really do hope that it tells us a little bit more about our recurrent implantation failure patients. Those are really, I think, some of the most heartbreaking patients. And as I said, we don't really even know how many patients fall into that category because it's so hard to actually achieve that diagnosis. So I'm hoping, honestly, that this testing becomes a part of a diagnosis of RIF, and maybe even hopefully like allows us to move that earlier into the clinical awareness for a patient, so that we can hopefully intervene, learn more about these patients, but intervene earlier. So that's my hope.
And it certainly resonates as someone whose own fertility journey didn't go exactly according to plan and wasn't the smoothest road. I certainly know that it comes with its challenges, and I can imagine the challenges of having multiple implantation failures and staying optimistic and staying persevering and continuing through that. We know that we lose a lot of patients along that path, and so certainly helping those poor prognosis patients is something at the top of mind for us, especially on our endometrial program. In terms of where the field of testing is going as a whole, I touched on it with the slide looking at sort of past, present, and future. We have a number of active investigations really looking at, yes, there is the timing component, when is the window available, but there's also the environmental component within endometrium. So ultimately, again, as I alluded to, for 26 or more days out of a cycle, the endometrium is refractory, it's on the defense, and it's really there's a balance of suppressing the maternal immune system to promote embryo implantation, but you also need to activate it for that vascular remodeling. And there is some actually compelling evidence that part of the RIF patient scenario is that the endometrium can actually respond to an attempt at implantation. I talked about those stromal cells starting off in sort of that naive fibroblast, but they can decidualize. We didn't talk about decidualization much today, but they essentially, the underlying stromal compartment can respond to an attempt at implantation. And if unsuccessful, those cells need to be cleared out. So menstruation helps do that. And that's sort of the human perspective of why mammals menstruate, is to help achieve some of that. But the immune system also plays a role in clearing of those cells, those senescent decidual cells. And so that's an element that we're certainly looking at, all things from the microbiome and causes of endometritis, inflammatory signatures, even endometriosis can drive inflammation within the endometrium, and then really just looking at that balance of the immune system. I think that will be something that I'm looking forward to learning more about in the years to come.
And correct me if I'm wrong, Mike, but we would love to, partner with any clinicians on the call who are interested in working with us on that research.
Always interested.
Okay. Well, thank you both. I'm going to turn it over to Emily to wrap up, as I know we're just at about time. But again, thanks, Mike and Kristine. Those were excellent presentations, and thanks so much for answering all those questions. And Emily, take it away.
Thank you so much, Sheila. And I think it was worth sneaking that extra question in at the end there. I enjoyed that one. Yes, thank you very much to Kristine and Mike for presenting. And thank you to you, Sheila, as well for being our host and quizmaster today. So yeah, thank you so much. And we greatly appreciate, because obviously you're from the US, and we hugely appreciate you helping our customers here in the UK and Ireland. So thank you very much. Our next genomics webinar is on July 13th at 1 o'clock, and it's a bit of a different topic. We're going to be looking at the genomics report cards, which will be launching very soon in the UK and Ireland. Our genomics report cards have information about different key performance indicators, and we'll be issuing this information to our customers on an annual basis. This information will be supplied to all of our genomics customers in the coming weeks. So please do join us as we talk through the results and give an explanation for the data. And to make sure you know about all of our webinars, please sign up for our fortnightly bulletin by sending an email to our customer services team. They're at customerserviceuk@coopersurgical.com. So it just remains for me to also say thank you very much for Danielle. You can't see her, but she's there in the background organising us all and running the webinar. And a big thank you indeed to our audience today. It's been a pleasure to have your company. Thank you very much for your questions, and we look forward to seeing you again soon. Have a fabulous evening.